It's my great pleasure to introduce our final speaker on a very energizing morning. Dr. Mike Mugavero needs very little introduction for this crowd, but he is a professor of medicine in the Division of Infectious Diseases. He is co-leader of our Center of AIDS Research and has also taken on a very important role for a number in the room and others in co-leading our T32 and K training programs, and we really appreciate his innovations in developing new infrastructure and ideas in the outcomes research space. Mike has published over 180 papers. He has been internationally recognized for his work in AIDS, quality of care, and patient-reported outcomes. In addition to his great research, he's also won teaching awards for his clinical services and does great clinical care and has been recognized for that as well. And it's really a pleasure to have him. I should also add that he's a great bridge with our other speakers because he's trained at Vanderbilt in medical school and he went to Duke for fellowship. I don't think you were at University of Michigan, though.
I went to Notre Dame, so that's kind of
oh, no.
diabolically opposed.
Welcome.
So thank you so much, Ken. Really appreciate the invitation to join, and thanks everyone for sticking around. Really honored to join the speakers today and thank Adrian, Paul, Amy for setting the stage so nicely for the work that I'm going to talk about. So we've heard a lot of really wonderful big picture talks about health system implementation science, and what I plan to share is a 10-year journey that we've been on, focusing on one chronic disease, HIV, but as an example of studying other areas, other chronic diseases. And I think to the question that came at the end, hopefully going to talk about how do you extend some of these findings from the health system out into the community and translate and implement some of these findings into practice, into research, some of the work we're trying to do now. So learning objectives for CME purposes, that might differ a bit from what's on the form, but really want to give an operational framework to study engagement and care. And I use engagement and care very specifically and distinct from access to care, and I'll make that distinction in terms of how we've operationalized that. How do you measure care engagement? And we'll focus a lot on the idea of within the health system, missed visits, first arrived or kept visits, capturing different behaviors. The prognostic value of missed clinic visits, so that this kind of very simple marker has great prognostic value for future care engagement and health outcomes, and to share just a couple of health system interventions that can improve care engagement. So relatively low cost interventions. Really enjoyed Amy's talk about quality improvement implementation. I feel like I straddle that world all the time in my work, and also the grassroots. So really my story is going to start with a grassroots study coming out of fellowship at Duke. I'm going to share, but first this idea of engagement in care. And I think the importance of access to care has long been recognized. And historically, access has been thought about these big population-based surveys, large administrative databases, asking questions like, do you have a usual source of care? Have you visited the emergency department in the last 12 months? So kind of these kind of global questions about someone's interface with the healthcare system. So shifting from access to engagement, going from a more global conceptualization of the interface with the healthcare system to more granular processes, more granular measures. Again, hope to share a conceptual framework where using HIV as a model condition for research and practice really is applicable to any chronic disease. I mean, speaking to the idea of having agnostic, I think a lot of these methods, framework approaches really are agnostic to disease, and that these operational definitions are very broadly applicable. So just some background, HIV basics. I know a lot of folks don't necessarily think about HIV infection very much. So a virus that targets the CD4 T cells of the immune system. So this is one of many immune cells in the immune system. As these CD4 cells are depleted over time by the virus in the absence of treatment, someone comes at risk for AIDS-defining opportunistic infections or cancers. So more virus, deplete CD4 count, someone develops clinical AIDS at risk of dying from AIDS-defining events, typically cancers or infections. The viral load is the amount of virus that's circulating in someone's blood, and it's used clinically for both treatment and prevention implications, and research is a really important surrogate outcome measure. And that we've had combination therapy since 1996, first called HAART, or highly active antiretroviral therapy, and it really transformed HIV. I mean, probably one of the greatest public health discoveries ever made in terms of the hundreds of thousands of life years saved because of this transforming a uniformly fatal illness into a treatable condition. And so the goals of treatment are to suppress that viral load to what's called undetectable. So a level so low you can't detect it in the plasma, it's in the blood. No one can be cured of HIV yet, but the viral load is undetectable, thereby increasing the CD4, so building back CD4 equals immune system, improving survival, improving quality of life. So I wanted to share a case study because I think it's really important. We talk a lot about now big data, population health, but at the end of the day, it comes down to one patient at a time. And we're talking about intervening with one patient at a time. And I think this is an illustrative case for what we commonly see in the healthcare system and setting, not just with HIV, but in any healthcare setting. So it was a 21-year-old African-American male was diagnosed with HIV in June of 2009. He established care, came to our clinic, started antiretroviral therapy, combination therapy 2 months later. So got into care pretty quickly and had a great response to treatment. So here's his trajectory. He's diagnosed. At diagnosis, has pretty advanced infection. So a CD4 count of 78 would be defined as AIDS. It's less than 200. Viral load was relatively high. Starts therapy a month later, you see a dramatic reduction. That viral load is already 384. His immune system is building back up. Comes back in a few months later. His virus is now undetectable. So it's fully suppressed in the blood. CD4 count continues to increase. And again, in February, comes back 3 months later. So here we are 6 months, from entering care, 8 months from diagnosis. We have someone who has really successfully engaged the healthcare system, started treatment, achieved success in these biomarkers. But then it got more complicated, as it often does. So had sporadic visits, missed visits, and then was lost to care entirely. As often is the case, the clinic tried with our locator information to contact him, couldn't get in touch, couldn't reach him, and he passively returned to care 2 years later. And that's when I first met him, was when he passively returned to care, had weight loss, night sweats, cough, and what's Kaposi sarcoma lesions. This is a malignancy, a skin cancer that's associated with the human herpes virus. So we look at his trajectory. We left off in February of 2010, where he was suppressed and had the CD4 count that was increasing, missed several visits, came back in November, viral load was up, CD4 count had dropped, his immune system was weakening, and then entirely disappeared for 2 years. And then showed up 2 years later. At that time, his viral load had increased dramatically. His CD4 count was again back in that AIDS level. Actually came for a lab-only visit, and I met him in April of 2013, where his viral load was even higher and his CD4 count had dropped further. Actually, beyond having the skin lesions of the Kaposi sarcoma, had it in his lungs as well. Very difficult cancer, very difficult diagnosis. And I think this case is illustrative of something that we see in our clinic every day in HIV. But I think if you're in a primary care clinic, a diabetes clinic, a mental health clinic, we see this all the time, where we have folks intermittently engage with the system, doing well for periods of time, disappear for a whole myriad of reasons, and then either passively come back because of symptoms, illness, other life-changing events that bring them back into care. And so I show this picture, this HIV treatment cascade, because this has become the centerpiece for studying HIV for a long time. And I've kind of shared with you this very individualized trajectory, but the way at a population or public health level, HIV has kind of been approached and looked at is that among those living with HIV, estimated 1.2 million people, that about 90% are diagnosed. So testing efforts have been pretty darn good. We've gotten most folks living with infection in the US diagnosed. Where we've really struggled is in this idea of engaged in care. So only half of persons living with HIV in the US are engaged in regular medical care. So this other 50% are out in the community, not in care, not accessing treatment, not receiving benefits of care. Once folks are engaged in care, most are prescribed treatment and the majority are virally suppressed. So once we get down to that end, if folks can get in and stay in care, they do really well. And what's been really interesting is that for the 30 years that we've been studying HIV, there have been hundreds and hundreds of trials comparing how does regimen ABC work compared to regimen XYZ. And we've improved iteratively from 80% suppression to 90% suppression, but these 50% of folks not in care, largely ignored as kind of a service problem. And the science is finally catching up in the last 10 years or so. But again, from a healthcare system perspective, I'm going to talk about some of the ways that we've studied this, a framework to study it, and then beyond the health system, how do you interface with the community, with public health to really understand how folks are engaging in their healthcare. And so this is a snapshot at a moment in time. I think that last case would show us our patient went from diagnosis through these steps to virally suppressed in 6 months. And at a population level, you could say, here's how folks are doing at this snapshot in the moment in time. But for each individual, it's so much more dynamic. Again, for any of us in our healthcare, it's such a dynamic process. So when I first came back to UAB in 2006, on a whiteboard in a conference room, we drew up this kind of blueprint for treatment success and this idea of engagement in medical care. And this idea that following diagnosis, someone has to get the next step of get linked to care. And now in the case of HIV, a lot of times the place of testing and the place of treatment are different. Might not be the same with high blood pressure, diabetes, other conditions, but might be the case where you have to go from one provider to another or one health setting to another or from a community testing place, screening place to a clinic. So the first step is getting linked to care, starting antiretroviral therapy and continuing to receive it. So both initiation and persistence on treatment while staying retained in care, optimizing adherence to improve clinical outcomes. And those clinical outcomes might be CD4, viral load, quality of life, any number, mortality. Re-engagement is intentionally in dashed lines because it wasn't a necessary step. Someone didn't have to drop out to get back into care. But in terms of setting up a framework to study this, we know a lot of folks drop out of care. So we had to have that as part of this process in terms of how do we identify who these folks are, where they are, and identify strategies to bring them back into care. Again, really dovetails nicely with the work at the VA, Amy, that you've done with mental health and re-engagement. So operationalizing that 50% who were not engaged in care, we've kind of broken down saying there's 3 distinct but interrelated steps. So the first is linkage to care, the next is retention in care, and the next is re-engagement. I think also really important is the bidirectionality, that each step impacts earlier steps. So someone's health outcomes influences if they keep coming to the clinic, keep taking the medicine. And so these relationships are not simply a one-way, but bidirectional, dynamic, and changing over time. So now I'm going to come back to where I jumped the gun a little bit. So when I finished fellowship at Duke in 2006, came back and thinking about a bottom-up approach, heard from providers, this is our clinic director, Jim Rapers, a nurse practitioner, a lawyer, director of our clinic, that a lot of our new patients are no-shows. They're not coming for their visits. So we said we can study that, we can measure that, we can evaluate that, and then do something about it. And so we looked at patients who called to establish care. The 1917 is the name of our HIV clinic from 2004 to 2006. And lo and behold, as is typically the case, the providers were right. About 1/3 of new patients who were calling the clinic failed to attend, failed to come in for an initial scheduled visit. And now when someone calls the clinic, we would capture some very basic information. So we could start kind of saying, in terms of who are these folks, who's likely to make it in, who's not likely to make it in. And what we found was there was a trend towards younger patients not making it into the clinic, not getting linked to care. But compared to white males, 80% of whom were linked to medical care, minority males, in our setting predominantly African-American, minority and white women, again, African-American women, were significantly less likely to get linked to care, to attend that visit within 6 months of the phone call. Compared to those with private insurance, 83% made it in. Those with public insurance on insurance, less likely to make it in. And then finally, the days of the longer the time from that phone call to the appointment, the less likely someone was to get into care. So the idea that on average it was 4 weeks. And how much happens in someone's life from now to 4 weeks from now that might impact their ability to make it into a visit. But the longer that time was, less likely someone was to get linked to care. So this was pretty cool. For me, I'm here coming out of fellowship. In August, these folks have this great idea. By December, we've got a brief report accepted, and I've got an engaged healthcare team that's into CQI and doing that kind of work. That was around Malcolm Marler, who was our clinic chaplain, brought together nurses, social workers, doctors, patients, clients, consumers of care to talk about, here's a problem, what do we do? And we launched this program in January of 2007. And the first thing that jumped out to us was 4 weeks is way too long for someone to wait from calling to coming in for a visit. So we're going to add an orientation visit within 5 days of the call to the clinic. And the median time is 3 days. And what we did was, in terms of thinking about cost and how we're going to do this, was this is now coordinated by social work services. So historically, someone would call, 4 weeks later would come in, have an hour social work visit, have an hour medical visit, get their labs and go, and I would bring them back pretty quickly to see them in follow-up. So now we uncoupled those visits. So the social work visit became the orientation visit, where we were able to do a semi-structured interview, a psychosocial patient-reported outcome questionnaire, and get baseline labs. So won't go into great detail in my talk today, but James Willig, who I've worked with for the last 10 years, with his kind of software development work. This was the first proof of concept for the PRO platform that's now been launched throughout a number of clinics within the UAB health system: rheumatology, palliative medicine, GYN, pediatric neurosurgery. And the beauty of this was, by uncoupling this, we got folks in within 3 days, got all kinds of information from them in terms of housing, marital status, depression, anxiety, substance use, stigma, social support, as well as baseline labs, so that now when someone comes to see me for my visit, I know so much about the context of who they are, their life, potential barriers to care. And this is a pre-post analysis, so it's a non-scientific, non-randomized design, but we saw dramatic reduction in terms of the no-show rate. So after launching this intervention, we dropped from a 31% no-show rate to an 18% no-show rate, became a quality indicator for us for the last decade, and has oscillated between 80% and 95% show. So, historically, we hovered around 60, 70%, 75% show, went up to 80, 95% show. So, good suggestion that this intervention worked, was successful, was implemented in the clinic successfully. And then the CDC has a compendium of best practices for interventions for linkage and retention in care. And this was named one of a handful of interventions to receive that designation. And thinking about, for this team, right? This wasn't researchers. This was a team of chaplains, social workers, patients, nurses that kind of came together with this, really empowering. I mean, in terms of owning this and feeling, the validation that they created this, they built this. And so a lot of the work that we're doing now with Project Connect, I've had more requests for information about this than anything else, is saying, can we deploy this? How do we deploy this in terms of having these PROs available, web-based, having systems of data capture? So thinking about, we've got this evidence-informed intervention, we have a lot of folks that want to use it. Our next step is, how do we deploy this in a way that we can both capture data, study, measure, and determine, is the impact that we observed more broadly applicable in other populations and settings? So that's kind of some of the future directions we're going with this work. So the next step was looking at missed visits. And this is probably the most impactful study I imagine that I'll ever do. It wasn't published in JAMA or in New England Journal or Annals. And it was such a simple question, but has really had a big impact on our field and kind of the work that we've done going forward. So, beyond having a challenge getting into the clinic, a lot of patients miss visits after they first come into care. So a really simple question, saying among 543 patients, relatively small sample, coming into our care, newly diagnosed, they made it in for a first visit between 2000 and 2005, what was the impact of having at least one no-show visit that first year on their long-term mortality? Start a survival clock at 12 months. And what we found was there was a 3-fold increased mortality risk. So by no showing for one visit, your mortality was relatively equivalent to coming in with immunologic aids, a CD4 count below 200. And the message of this back to providers was, we're not suggesting this early no-show is causally responsible for someone dying subsequently, but wow, in terms of a prognostic marker telling us this is someone who might be at risk, this is someone who might have more going on in their life that requires attention to understanding and intervening upon, that's a pretty powerful prognostic marker. And again, a small study, but impactful. I mean, later that year, the HIV guidelines came out and added a new recommendation based upon that study of 500 patients and a VA-based study saying that the importance of adherence to care has to be focused upon rather than just focusing on adherence to medication. So historically, it's adherence to medicines, but if half of folks are not in care, if we don't study adherence to care, we're really missing the population level impact. So I show this now to talk about what does it mean to be engaged in care or retained in care. And so this is an example of 4 different patients. If we think about across the UAB health system, we could kind of make these kind of diagrams for every single patient that comes in and interfaces with our healthcare system. So this was a 12-month period of time, because historically in HIV, folks would come in every 3 months for a visit. So we said a 12-month period of time. We used check boxes to indicate an arrive visit. Someone came and attended, an X box to indicate a no-show visit. Someone didn't call in to cancel their appointment. By convention, historically, canceled or bumped visits, if someone calls ahead, have not been included analytically for research purposes. Huge opportunity, but the idea of someone that's calling in to cancel treated differently than just not showing up for a visit. So operationally, imagine 12 months, these 4 3-month intervals, here's these different patterns, and you say, what does it mean to be engaged within the healthcare system over this time? And here's 5 different measures that have been used in the literature. So different ways to operationalize what does it mean to be retained or engaged in care. So the missed visits one is relatively simple, either as a dichotomous measure, yes versus no, or a count measure. You can go across each patient and say, do they have an Xbox? If so, how many of them? And kind of calculate that measure. The appointment adherence resonates with medication adherence. So over a total of X number of scheduled visits, how many did someone actually attend? So the attended over the total visits. So for the first patient, you could say they came to 80% of their appointments, second patient a third, last patient came to 100%. The idea of visit constancy is getting around, did someone attend a visit per interval time? So again, historically in HIV, it'd be every 3 months, saying, did someone come to at least one visit every 3 months? So is there a checkbox in each of these 4-month intervals? And you can see for that first patient, they did. They're 100%. Even though they missed that visit, they came in each interval. For that second patient, they only came in 2 of the intervals, so they're 50%. The third came in 75%. They didn't miss any visits, but that third quarter, whether they canceled, whether they weren't scheduled, they didn't have a visit, so they'd be 75%. And the last patient, they had 2 visits, but both in that same interval, so they'd be 25%. Gap in care, very intuitive to providers. Was there 6 months time or some period of time between arrived visits? So you could say for these patients, patients 1 and 3 did not have a gap. The other 2 patients did have a gap of more than 6 months. Then the HRSA-HAB measure is a quality improvement measure. So it's used for quality purposes and says, did someone attend at least 2 visits that are 90 days apart in a 12-month period? So you could say the first 3 patients, despite having very different kind of profiles and patterns, all 3 of them attended 2 visits that were not within the same 90-day window. So this quality indicator would say patient A, B, and C were all retained in care, whereas the last patient, despite having 2 visits, they were both in that same 90-day period, so you'd say they were not retained in care. So just kind of breaking down, how do you operationalize from a health system perspective, looking at care? We have lots and lots of care visits. How do you operationalize and break down? What does it mean to be engaged? Broadly speaking, there are measures that include missed visits, and that includes that missed visit measure, the appointment adherence, or the flip is the no-show rate. And then there are those that are based solely upon arrived visits or attended visits. So that idea of constancy, coming per interval, a gap in care, HRSA-HAB, or another HHS measure that are used. And I think what's critical to point out thinking about health systems and health systems research is that typically health systems uniquely capture missed visits. I think most administrative systems capture when someone shows up, a claim is made, so you capture the presence of attending and arriving, but health systems are uniquely positioned, to my knowledge, to really study and understand how to missed visits have an impact in terms of patient health and population health. So this was a study we did. It was before doing a 6-site intervention trial to improve retention in care. So we looked at the 12 months before launching the intervention trial. We had over 10,000 patients across 6 different sites and said, we're going to take those 10,000 patients, draw their little line with all their visits, and categorize them based upon how they would perform according to these metrics. So same patients, same visits. And what you find is very striking differences in whether you'd say someone is engaged or not based upon how you define engagement. So on average, patients had 1.5 no-show visits. Only a third came to all their appointments, had 0 no-shows. So if you said to be an engaged patient, you can't have any no-shows, you'd say a third of the patients were engaged during this 12-month period. For visit adherence, again, you see a broader distribution. It's just kind of accentuates the no-show in terms of the data, but a third are not retained in care. When you go to this kind of kept visit measure, did someone come at least once every 4 months? And we use 4 months instead of 3 months because practice patterns change. We're seeing folks less frequently. And what you found was only half of patients arrived at least once in each 4-month interval. You say half of them are retained. When you go to the gap, you would say that 2/3 are retained because they did not have a gap in care. And by the HRSA-HAB, that 2 visits 90 days apart, you'd say that 77% were retained. So again, the same exact 10,000 patients, the same exact visit data, kind of just measuring them different ways, you would get very different kind of answers in terms of, did this patient engage in the health system over the last 12 months? And so looking at a correlation matrix, and probably not surprising based upon those findings, were that the missed visit measures, very highly correlated, very high correlation coefficients for the missed visits, visit adherence, whether counter dichotomous. Kept visit measures, similarly, very highly correlated. But what was interesting was that the correlation coefficients were much lower across the missed visit and kept visit measures. So again, same visits, just characterizing, measuring them differently. These correlation coefficients are much lower. So the next question we asked was, how about predictors of these different measures? And we see a lot about disparities in care, disparities in HIV care. Are there disparities in engagement in care based upon these measures? And for simplicity, there's different models and didn't want to go into the details. Green means better retained, red means worse retained. So looking at these missed visit measures, you would say older patients, men, and white patients relative to African Americans are better retained in care. You'd say there are clear healthcare disparities in terms of who is engaged in care. But if you then look at these same patients, same data, same visits, and base it upon how many visits did they attend or arrive to, you see the same findings in terms of older patients versus younger patients, but women compared to men, in one instance, actually performed better. And African Americans compared to whites had the same. So really begging this question, same patients, same data, is that are missed and kept visits capturing different aspects of engagement in care? And I think that they really are. There's something different about getting to an appointment at some interval and some frequency versus missing appointments. Thought a lot about the role of different structural factors versus psychosocial factors. How does having housing, transportation, relative to your stigma, resiliency, coping skills. But I think this is a really important area for study in terms of really understanding. These are capturing different aspects of folks engaging with the system. What does it mean to miss, and what does it mean to keep, and how do we intervene to improve them? So what was really striking was that despite them seeming to capture a different aspects of engagement in care, they all were strongly associated with viral suppression. So when we looked at how did these different measures of engagement in care correlate with viral load suppression as an outcome measure, all of them strong, significant associations. So the better retained, more likely virally suppressed, varying discriminatory capacity based on C statistic, and not surprisingly, those that are dichotomous were less discriminatory. Those with more continuous measures had better discrimination. But the idea that there's no gold standard, so they're all measuring something valuable. They're capturing something meaningful and valuable, but that missed and kept visit measures are tapping into something different. So subsequently, we went on and did the intervention trial. And this was through the CDC, these 6 sites. And phase 1 was a clinic-wide intervention, a really simple intervention. So put up posters, put up brochures. There was a training for the clinic staff, everyone, to emphasize engagement in care from the front desk. It's great to see you today. It's been a while. How are you doing? Through the visit, nursing, vital signs to the lab. So creating this clinic culture for retention and care and evaluated by a pre-post study design. And the phase 2 was a patient-level behavioral intervention. So identifying patients who had poor retention by missed visits in the previous year and enrolling them in this study was a pretty simple intervention in terms of enhanced personal contact. So personal reminder calls, 7 and 2 days before a visit and within 1 or 2 days of a missed visit. And it was the same person every time. And when someone enrolled in the trial, they met that person, they developed a relationship, so they knew who this person was. It wasn't a random person, it wasn't a robocall. It was a person and the same person every time. And there was a 2-session skill buildings on problem solving, communication, organization, and did this multi-site RCT to evaluate phase 2. And so what we found for the phase 1 was that it improved clinic-wide visit adherence. Pretty modest, a 3% improvement. There were some better improvements for newer re-engaging patients, those with high viral loads and low CD4, so some priority populations. But relative to the cost, I mean, a pretty low intensity, low cost intervention to do. And our colleagues at CDC did some cost analyses and demonstrating that by improving the clinical efficiency, by having more kept visits and fewer no-show visits, the average clinic would increase their revenue by $24,000. So it would actually improve clinic revenue because it's relatively low cost and you're getting more encounters that are attended and folks there. So the phase 2 for improved visit adherence, again, modest improvements, but the overall retention and care increased by 5% based upon visit adherence. Improved among, again, the populations that seem to be having the greatest challenging. African Americans, women, those lacking private health insurance had the biggest impact of this intervention. And in terms of the cost analysis, the cost per additional patient retained in care around $4,000. So a relatively modest cost to retain one additional patient in medical care. So I want to talk now about some of this work we've done, both in a quality frame, in a research frame, and how we're now working to kind of translate this into the community and extend this beyond the academic health system with community partners. So the Alabama Regional Quality Group is a group of 8 different HIV clinics around the state of Alabama, provide care to between 80 and 90% of persons with living with HIV who are in medical care. And the group, down here you see, the quality group management exists to ensure that those living with HIV/AIDS in the state receive quality health care through collaboration of healthcare partners throughout the state. The collaboration aims to continuously improve the quality of HIV care consistent with recognized national standards and current research. And this group has come together and agreed upon aggregate data we want to capture for viral load suppression, for missed visits, for retention and care, meet quarterly aggregate data, share data. And one of the things has been this no-show percentage. So across these 8 different clinics, it ranges as low as 18% clinic-wide no-show to as high as 32%. This is a colleague down in Montgomery, Ashley Tarrant, shared this slide. But this has become a kind of target for us, saying there's challenges and these clinics can improve clinic-wide in reducing their no-show rate. We have this evidence-based intervention that we could deploy. And so there's a lot of discussion about, well, how do we do this? How are we going to deploy this? Can we implement this trial through the network? And one thing we've talked to them about, because one of the challenges were we don't have the resources to do this for everyone. We can't call everyone, doesn't make sense, was looking at data from the CNIX cohort. This is an 8-site clinical cohort across the country, over 20,000 patients, and wanted to look at missed visits for risk stratification. So the idea of, can we predict who's going to miss their next visit based upon past behavior? And we actually tried to do more sophisticated prognostic modeling, adding PROs for depression and substance use and all these things. And it turned out that to add that complexity and elements didn't give us that much more prognostic value. And that simply knowing someone's visit behavior in the previous 12 months, we could reasonably predict who was going to miss their next appointment. So about half of the clinic population hadn't missed any visits in the previous year. And they accounted for their no-show risk was 9% for that next visit. So I mean, pretty low. 35% of the clinic population had missed 1 to 2 visits. Their risk of no-show was 22%, and 15% of the clinic population had missed 3 or more visits, and they had a 35% no-show risk. And all these folks attended and were in the clinic and were in front of you. So here they are, they're here, they've made it to this visit, and we're saying your risk is 9%, 22%, 35% of missing your next visit. So we're in discussions now with the regional quality group about, can we do an implementation science trial? Can we evaluate that CDC retention and care study, but using a tailored intervention? So if you risk stratify and say someone that's had 0 no-shows the previous year, leave them alone. They get no intervention, they're probably gonna do okay on their own. Someone that missed 1 or 2 visits, they get kind of the simple intervention. So those personal reminder calls, those follow-up no-show calls. Someone that's really at higher risk, they've missed a whole bunch of visits, they have a 35% risk, they get that simple reminder call intervention, no-show visit intervention, plus whatever your best practice is. Not gonna try to add something new, but say if you have intensive case management, if you have peer navigator, patient navigator, let's deploy that intervention. So more of a strategy trial, trying to say we have an evidence-based intervention that works. We can pretty easily at the point of care risk stratify who is in most need of the intervention. Can we have a strategy that works to improve both individual but clinic-wide retention and care? So going to step back now from the health system perspective and look more broadly at the interface with the community. And I think, we talked about this work starting in the clinic, going through these trials, now through this clinical network, and now wanting to go back in the interface with the community. And historically speaking, a lot of work in the community was done by community-based organizations in public health, and was a lot of testing work and prevention work. And within the clinic was all the work, once someone was diagnosed, you're linked to care, you're retained in care, you're on treatment, and we're very separate. So the community work in prevention, the clinic work in treatment were really separate. But the idea that, if half of folks are not in care, we've got to think about this interface and how do we bridge the interface between the community and the clinic, both to get folks into care, but those that fall out of care to kind of bring them back into care. And the Jefferson County HIV/AIDS Community Coalition has become a grassroots organization to help us mobilize and try to better bridge the community and the clinic. So in March of 2013, we came together. In January, we convened an Ending AIDS dialogue with stakeholders throughout the state. And after that meeting, folks said, we have all the resources, we have the tools, we have the people, we just need to kind of collaborate, work together, communicate. So starting in March, this group came together, included all the community-based agencies, local public health and state public health, and those two don't always work well together and get along. There's sometimes challenges in that interface, as well as all the clinics that are providing care and the Center for AIDS Research to give some kind of operational research support. And so this was a picture taken early on, and this group, defined goals and wanted to be very broad in our goals and broad in our thinking. So we wanted to improve health outcomes, wanted to enhance prevention, treatment, and research, wanted to improve social and economic justice, foster community collaboration to achieve parity, inclusion, representation, and to identify, evaluate, and apply for alternative sources of funding to maximize sustainability. And this group has met every month since March of 2013, and it's really been a great success. And it's led to a number of different demonstration projects. So AIDS United is a foundation, funded 2 demonstration projects, one to AIDS Alabama community partner called Living Well. This is a peer navigation-based model for folks tenuously engaged in care, trying to improve their interface at that community clinical interface. The other was Birmingham Access to Care, a community-based case management study done with our partner Birmingham AIDS Outreach. So starting to kind of bridge that interface between the clinic and the community around care engagement. So I come back to now, as a clinic, as a health system, one of the challenges that we faced, and how do we engage our community and public health partners to kind of address that problem. So in terms of our loss to follow-up, in terms of our CQI, going back as long as the clinic has existed for 28, 29 years, what's been amazing is among patients we'd seen in the previous 24 months, we hadn't seen 8 to 12% in the last 12 months. So the idea of the loss to follow-up for 12 months was 8 to 12%. So people we saw in 2010, we didn't see 10% in 2011. And if you look over time, very stable, very consistent, that we lose about 8 to 10% of our patients, 8 to 12% of our patients to care. And it's always begged the question of are these patients really lost to clinic, or are they truly lost to care? People migrate, they move around, there's other clinics, other places to go, and we haven't systematically had a way to know if someone's not in care at our clinic, are they in care somewhere else? And that all changed with Data to Care. And this is a CDC-led initiative that encourages state and local health departments to use surveillance data for HIV to improve the continuum of care. So, and our coalition kind of spearheaded this. That picture was taken in August 2014, really encouraging the health department to engage in Data to Care. And the way this works is that HIV positive tests are reportable through surveillance, as are viral loads. So viral loads as a lab measure become a surrogate marker for a visit. If someone has a viral load equals a visit. It's not perfect. You can get one in the emergency room in the hospital, but the idea is that a viral load equals a visit. So if someone has a positive test and there's no viral load in surveillance, it would suggest someone hasn't linked to care. And for us as a healthcare setting, we were able to say, here's the 10% of folks we haven't seen the last 12 months. Do you have viral loads for them? Can you link up with your data to tell us who's really not in care? And we piloted this for the first time earlier this year, and we found out that among our 250, 300 folks who were out of care, only 40% were truly out of care. 135 were in care somewhere else. Some had died and we hadn't heard about it yet, and they couldn't locate some others. But now through this kind of system integration, and again, I think there's other ways to do this. Not everyone has reportable labs like HIV. In some states, there's diabetes registries. You could do this, but by partnering with whether it's public health, insurance companies, other hospital information exchanges, you can kind of better really get a sense for, among those who are lost to follow-up, who's really lost, who's not really lost. And so now our work of trying to reconnect 109 people versus 300 becomes much more manageable, much more doable for us. And what's been really cool is that through the coalition, we're able to receive 2 large CDC projects that have really grown our workforce in terms of frontline providers. So these are community case managers, these are community social workers, linkage coordinators. Not all these folks work on these 2 large CDC grants, but many of them do. These are folks from public health. So we've convened this group the first time last December and then November, and brought together the boots on the ground, the frontline providers, because ultimately that's who's going to determine if we're successful getting folks in care, keeping them in care. And for us as a clinic, very limited outreach for those 109 people to get them back into care. But now through these projects and through these partners, we have folks who are in the community, embedded in the community, to do this outreach and activity to bring folks back into care and extend what we're doing. So in terms of next steps, Data to Care, how are we implementing and where are we going with this? The Reengagement Program has been expanded beyond us as the pilot clinic to all the other clinics in the regional quality group. So now we have all 8 clinics throughout the state sharing their data. Here's our loss to care, send it to the health department, get back, here's your active case list to work on. Capturing, reporting on our efforts, and then expanding to linkage to care. And so I want to come back to this case just to kind of close it out where I started. So he came back in to care, started HIV medicine, started chemotherapy. He missed a visit, and the nurse practitioner I work with called him. I was sitting there, Gina Dobbs called him. So what's going on? I need to see you. And then he had improved retention viral suppression, and he still remains in care. So came back in, was in bad shape, got on treatment, missed that visit, came back, and has since been on treatment. It's been a bumpy road. I mean, he's missed some visits, he's been on and off therapy, but I think those personal reminders, personal relationships for him have kept him with us, and more often than not, his virus under control. So just to summarize, in terms of engagement and care, this idea of a treatment cascade, I think if you looked at it for diabetes, as some have, or other conditions, it might not be 50% of folks with the condition are out of care, but it's probably a good number. And these are folks that are traditionally not engaging in the healthcare system that we need to figure out where are they, how do we get them back into care. That's this idea of linkage, retention, re-engagement, distinct steps. I hope I've impressed that missed and kept visit measures are capturing distinct aspects of healthcare engagement. And I think there's huge untapped potential within the healthcare system to study visits. And the beauty of visits is kind of like lab data. They're pretty good quality data in terms of all encounters are captured in software that are linked to billing. So those data tend to be pretty good in terms of if someone arrived, if someone missed. So there's readily available data elements to kind of measure, capture, study this beyond HIV and other health conditions. There are very low cost interventions that you can improve care engagement. So one was this Project Connect. We're now trying to deploy to other HIV clinics, the other intervention for retention and care. But that ultimately community and public health collaborations enhance both the science, I think we're doing better science, but also the service delivery. So coming back to starting with one clinic with 3,000 patients to now engaging all the clinics in the state with 8,000 patients and with community partners to get the remainder of folks not in care has really expanded both what's on the horizons for research, but I think ultimately to improve individual and population health. And so it's really cool. So from that whiteboard 10 years ago where it was just kind of a blank board, we now have this incredible team of engaged community people, both at UAB, but also in the community and across the state. And we have now set ambitious goals that we're going to end AIDS in Alabama in 5 years. And I think that wouldn't have been imaginable 5-10 years ago. So a lot of folks to thank. I can't thank everyone by name at the clinic, the health department, the coalition, the regional quality group, and the CFAR. And this is our research team, Research Informatics Service Center, that James Willig has been my partner in crime the last 10 years. And we've grown from a pretty small group to a large research informatics team and a great administrative team. So thanks so much, and happy to take questions.
Hi.
Hey.
I have a question. I get curious about your last case. So you show that patient get missed a visit and then come back to the clinic, and then he's HIV get really good control.
Mm-hmm.
So do you ever do the research about what's the maximum tolerance of their missing the care, to their healthcare management for the HIV patient?
Yeah, no, it's a really good question. So we've explored that a little bit. One of the challenges in terms of what is the optimal frequency or tolerance or those things is relative to what outcome. So if it's relative to viral load or lab data, typically those measures are tethered to coming in for a visit. So it's kind of hard without that. Those surrogate measures often are missing. They're not missing at random. But relative to a hard outcome like mortality, we've looked at kind of mortality, but not to the degree you're talking about. We've looked at these different measures and shown their association with mortality. Interestingly, even among people that meet the quality indicator for retention and care, there's a dose-response relationship in terms of the more times they've missed, the higher the mortality. But in terms of the tolerance or that kind of a threshold, we haven't done that kind of modeling work.
It was very inspiring.
Thank you.
With respect to the question on the intervention that you conducted, what was the length of that intervention?
So the intervention, the individual level intervention?
Yeah, the individual level.
It lasted for 12 months total.
Okay.
And there was the 2 personal visits that corresponded with clinic visits. So they weren't extra. I mean, it was just kind of a brief interaction.
Right.
And it was amazing, despite our care team, including a physician, a nurse practitioner or ID fellow, a social worker, and a nurse, this extra person how impactful they were for the participants in the study. I mean, and even after the 12 months and kind of graduating from the study, a lot of them were very sad that this relationship had to end.
Have you followed up after the intervention to see how sustained?
So the CDC has the aggregate data, but hasn't reported on it yet.
Okay.
I can tell you what we've done at the clinic based upon these series of studies is we've used 340B, revenue to hire. We have 4 engagement coordinators. So we actually have 4 people that are now part of our clinic team and have expanded our healthcare team to 5. So now this person that's doing the personal phone calls, missed visit calls is now kind of a new member of the healthcare team, but that's been our implementation plan.
So you've made it standard of care, sort of.
Great. Well, I want to thank Bugs for a really terrific talk, and one that really ties in health systems interventions to community-based participatory research using health informatics systems. So this is really a